talk about the NP001 trial, and just
Can you speak up a little bit, please?
I will try. So I'm going to do a brief review, just some very basic information. ALS, of course, is a disorder of the nervous system with loss of motor nerve cells causing progressive muscle weakness. And the cause of ALS is still unknown. We'll talk more about that just briefly. And we don't really have an effective therapy to stop or reverse the disorder. And that's the reason that we're very interested in clinical trials to try new medications that might possibly be helpful. So I said we don't know the cause of ALS, and I think that's generally true, but there are some exceptions. We know that there are clearly some hereditary cases, and that makes up about roughly 10% of ALS cases. And a large number are what we call sporadic, where we don't have a family history. These are just some theories about possible causes for ALS, the possibility of some environmental toxin. That idea is still out there. The possibility of a viral illness has been speculated but never proven. We have examples of poliovirus and West Nile virus that cause diseases of the nervous system that are very similar, but yet no virus has ever been found in ALS patients. The idea of trauma has been considered. That's still a speculative mechanism. And then lastly, the immune mechanism we're going to talk a little bit about today with NP001, the idea that the body's immune system is in some way involved in not necessarily causing the illness, but in the spread of the illness. As we know, ALS spreads from one region of the nervous system to others over time, and the immune system may be involved in that possible spread. So the NP001 trial was sponsored by Neuraltis Pharmaceuticals. It's a small pharmaceutical company in the Bay Area. The principal investigators, Dr. Robert Miller and Dr. Mike McGrath, both from San Francisco. This was a one-year trial that was completed in October of 2012. So it's very current information that I'll be sharing with you. The results from this trial are not yet published. The final analysis is not completed. What I'm going to be talking about is a preliminary analysis that has to do with the first 6 months of the trial. And this was presented at the ALS MND meeting in Chicago this past December by Bob Miller, the lead investigator. Now that's part of the reason that you don't have slides in your handout on this talk, is that a lot of the material that I'm going to be presenting is not my own to share. It comes from Neuraltis Pharmaceuticals, so I'm not able to give that to you. So this is a phase 2 randomized double-blind placebo-controlled trial. That's a big mouthful. How many of you know exactly what that means? Okay, a small number. And let's just see the hands of those who don't know exactly what that means. So I figured that might be the case. So I wanted to take a little bit of time to just give some very basic information about clinical trials, because a lot of this terminology is foreign to patients and family members. So let's just go through this a little bit. So what exactly is a clinical trial? A clinical trial is simply a test to see if a treatment works. So when we're doing a test, we usually have two groups. One group that will get the treatment, and the other group that typically gets a placebo, with the idea being that the placebo isn't going to do anything. Although that's not entirely true, there are studies that show placebos actually do something. But still, this is the standard approach to clinical trials, is to take a medication and test it in the one group that gets the medicine and one group that gets a placebo. So group A and group B should be similar in every respect. Similar characteristics, similar numbers of patients in each group, in order for there to be a proper comparison. And before a trial is done, a measurement is determined, or what will be used to measure if the treatment works. How are we going to know if this treatment works? And that's called the outcome measure. And so that's established before the study is conducted, what exactly will decide if the treatment works. So the outcome analysis, as I just said, that this is a predefined outcome measure to determine if the drug is effective. I'll also be talking today about something called a post hoc analysis, where one looks at other aspects, other measures that were possible to assess in the trial that weren't the declared outcome measure. because sometimes this post hoc analysis can reveal additional information. And that's the case with this NP001 trial. So what does the double-blind term refer to? Well, what that means is that neither the patient or the investigator knows who's getting which therapy. So that's what the blind means. We don't know. And the reason for this is to keep the evaluation fair and unbiased. Because if we knew who was getting the therapy, we might give them a preferential rating. We might evaluate them and say, oh, they did better, because we all want the therapy to work. Likewise, patients could have that same impression that they're doing better because they want to do better. Randomized. This term randomized has to do with how patients are allocated into the study medicine or the placebo. So the decision for who gets what is a random event. Nobody has any control over this. It's like tossing a coin. And again, the same reason for that is to keep the evaluation unbiased, so we're not putting our favorite patient in the treatment group and someone we don't know gets the placebo. So everyone has an equal chance. Now, trials are defined by, or one way of looking at trials is the term phases. There are different phases that a trial can be. And this study that I'm talking about today was a phase 2 trial. I'll just quickly say that phase 0 is a very preliminary exploratory study, and phase 4 is a post-marketing study where the effects of the drug are looked at after it's been approved and it's on the market. We're not going to spend any more time on those. We're going to talk about the other 3 categories. So phase 1 studies are typically safety studies, looking usually at healthy volunteers to determine if there are any adverse effects of the drug and to determine how the drug is metabolized in the body and how it's excreted. A phase 2 trial is a preliminary efficacy study where there's a preliminary determination if the drug might work. This involves patients with a specific disorder, involves a placebo, and there's also, at the same time we're looking at efficacy, we're getting more information about drug safety. And then a phase 3 trial is the confirmatory efficacy study, which involves a large number of patients to determine if the drug really works. This is the definitive trial to prove if the drug works. It's also typically a randomized, double-blind, placebo-controlled. So now you have an idea about those terms that I used when I said that this was a randomized, double-blind, placebo-controlled. So that's what this is. First I'm going to give you a little bit of a summary of the trial, and then we'll talk about the specifics. So in this trial, it was a 12-month study, but patients got 6 cycles of NP001. What we learned was this medication is generally safe and well tolerated. There were no really major problems with the medication. And we found that in the high-dose group that got the high dose of this medication, why is it doing this? In the high-dose group, there was some evidence of benefit. And we'll talk more about the ALS FRS slope, that there was a change from the baseline ranging from 13 to 19%. And the most important aspect of this study we'll talk about is this, what I call the post hoc analysis, where we saw that in a subset of patients, progression was completely halted throughout the 6-month period of study. That was in about a quarter of the patients. And it was concluded that the hypothesis that this supports an anti-inflammatory mechanism for NP001 was supported by the results, and that the benefit seen in this trial supported further development of NP001. So what is NP001? Well, this is a chemical substance. It's called sodium chloride. It goes through a special process to make this something that can be given intravenously. And this is a regulator of the immune system. It changes the macrophage function. The macrophage is one of the cells of the immune system. And in ALS, we have learned that there is an inflammatory, damaging role for the macrophage. So in ALS patients, the macrophages aren't acting normally. And NP001 has the ability to change the macrophage from being a damaging cell to be a normal supportive cell. So what's the evidence that macrophages are involved in ALS? Well, one of the big pieces of evidence came from Dr. Stanley Appel, who did a study that showed that there were macrophages invading the spinal cord of ALS patients. Large numbers of macrophages in the spinal cord, and that's not normal for that to happen. So this provided evidence that there was some involvement of, let me go back, involvement of the immune system in ALS. But there have been many trials of conventional immune therapies for ALS patients, and none have worked. And so even though we were aware of this information, we did not have any means to alter the immune system with conventional treatments. When I say conventional immune treatments, I'm talking about medications like prednisone. There are many other immune therapies that we can use, IVIG, plasmapheresis. All of these things have been tried in ALS patients and they didn't work. So this is a cartoon showing the idea that this is a macrophage in the normal state, and in ALS the macrophage becomes activated to become more of a destructive cell. It's involved in inflammation and damage to the nervous system. This NP001 has the ability to reconvert the macrophage back to a normal functioning macrophage. Now this is a schematic of the trial design, and what we see here is the screening visit, and in patients who were enrolled in the trial, they had 6 months of treatment, and patients were randomized to either a placebo, a low dose, or a high dose of NP001. And they got cycles of treatment over 6 months, with the very first cycle having 5 doses, and then each monthly cycle there were 3 doses, and then 25 days off. And that was the extent of the treatment, 6 months of treatment. And then the rest of the trial, the following 6 months, was a follow-up period where patients were followed to see how did NP001 affect their function. So in this trial, the primary outcome measurement was the ALS-FRS slope. How many of you are familiar with that term, the ALS-FRS slope? Okay. So what the ALS-FRS is, FRS stands for a functional rating scale, and this is a numerical scale that ranges from 0 to 48 points, with the high number being good function, low number being loss of function. Typically, in the average ALS patient, the FRS goes down by about 1 point per month. So if we plot this, if we use the ALS-FRS as our outcome measure, if we plot it here with a high score being up here and a low score here, and we plot this over time, what we anticipate is that there will be a gradual decline by 1 point per month. So this has been a commonly used outcome measure for clinical trials because it measures the functions that an ALS patient has. So if a therapy was a poor therapy and actually caused problems, we might see that in fact the FRS declined even greater than expected. If we have a therapy that is effective, what we would hope for is that the ALS-FRS would go more toward level and show less progression. So that's the measurement that was used in this trial, and that gives you some idea of, when we're talking about the ALS-FRS, that it's a summated numerical score based on function. So in this study, the primary outcome measure, as I said, was the FRS, and secondary outcome measures, meaning that there are other things to look at, included a number of different variations on the ALS-FRS. And one thing that was done in this study that the FDA allowed was in the secondary outcome measure to add historical controls to the analysis. So what does that mean? That means we were able to increase the number of patients that were analyzed by using results from other patients who weren't actually in the trial. They had been participating in another trial, and that information was incorporated into this to increase the numbers. And that involves a statistical analysis, but in order to prove something statistically, you're helped by having larger numbers in the study. And that was a step that allowed us to gather more information. And then I talked about this other post hoc analysis. I don't know if you can all see this at the bottom. This allowed a look at the patients who did not progress on their ALS-FRS throughout the 6 months. And that was a separate analysis that we'll talk about. This is a look at the characteristics of the patients in the trial. Remember, I said it's important that the groups are similar in all their characteristics. And I won't go through all of this, but just looking at the different groups, the placebo, the low dose, and the high dose, you can see that for all of the characteristics, the sex, the age, the duration of ALS, type of ALS, site of onset, etc., everything was very similar. So let's just look at a couple of these. So for age, the mean age was 53.7, 54.4, 53.6. And anyway, the groups were very well balanced in terms of characteristics of the patients. Now, as far as side effects, as I said at the start, there were very few serious side effects. Probably the most common, or the side effect that was more prominent in those who got the treatment was the infusion site reactions. And you can see here, this is an intravenous therapy, so they're getting the medication through an IV. And the group that had the high dose had a higher incidence of infusion site reactions compared to the lower dose in the placebo. And that's expected when you're giving a medication intravenously, that if it's a placebo, it's going to be much less likely to cause a problem, a local reaction. Overall, I won't go through all of these, but overall there were very few significant side effects with NP001. So this is one of the first analysis looking at the slope of the ALS-FRS through month 6. And what we see here is that the higher dose had a 13% improvement compared to placebo. So the ALS-FRS was, the slope declined less rapidly than the placebo group. Looking at the ALS-FRS with the historical placebo group added, it was even a better result, 19% improvement in the high dose compared to placebo. Looking at the change of ALS-FRS from baseline through month 6, we see that there's also a 19% improvement with the high dose. So there was a trend that the low dose and the high dose both had effects. Now, another thing that was looked at, we didn't talk about this, but there were some blood studies done that looked at measures of inflammation. And this CRP stands for C-reactive protein. That's a measurement that one can look at in the blood that has to do with inflammation in the body. And this showed that that the patients who got the high dose had the greatest reduction of the CRP measurement in the blood compared to placebo. So that was further evidence supporting the idea that this, in fact, may be affecting the immune system function. Now, this slide is probably the most important one because this was the post hoc analysis that really created a lot of interest in this drug, where we looked at the patients who did not progress through the study, through the 6 months of treatment. And we saw that there was a dose-dependent increase in the number of patients that did not progress in the study. So in the placebo group, 11% of patients did not have progression throughout the study, 6-month period. The low dose had 19% did not progress, and the high dose, 27% of patients did not progress. And so that's actually a quarter of the patients didn't have progression for the 6-month trial on the high dose therapy. So that was considered very exciting and encouraging that the high dose may be effective for ALS. So this was the first time this has been tried in ALS patients, and so now we have a better idea too that a higher dose is more likely to be helpful than a lower dose. So when further studies are done, we'll likely be using 2 milligrams per kilogram or higher. This is just another look at the same thing, looking at the patients who did not progress, showing the graphic illustration of the FRS being stable over time, which is not expected. We expect the ALS-FRS to drop down over time. But in this group, 27% of the high-dose treatment group did not have the typical progression. So, conclusions, something happened with this slide. I don't know why that did that, but in any case, summary and conclusions. The NP001 was safe and well tolerated. There were no major adverse effects. There was a modest benefit in just looking at the predefined measurement, the slope of the FRS declined from baseline in the range of 13 to 19%. The post hoc analysis that I talked about showed that this 2 milligram per kilogram dose, the high dose, really stopped progression in 25% of patients. And that was unexpected and very exciting that this may be a medication that's helpful for ALS. And finally, that the trend of the C-reactive protein measurement supported the idea that there was an anti-inflammatory mechanism of action for NP001. So where do we go from here for future use of NP001? There are plans for a larger phase 3 trial. It's anticipated that it will occur this year. Thus far, there is no actual announcement of when this will start. And this has to do with the pharmaceutical company Neuraltis being able to have the resources to conduct the trial. And they are looking for support from a larger pharmaceutical company to help them with this. So I'm going to go ahead and stop here and take any questions you have. Yes?
I have 2 questions. Where did you do this, the trials?
Where was it taking
Here?
place?
In Phoenix?
It was at multiple medical centers across the country.
Across the country?
Yeah. We were one of the centers at Mayo, and there were centers all through the country that participated.
And you would sign up for it through your doctor?
Yes. I didn't talk about the eligibility requirements, but every study has eligibility requirements, what we call inclusion criteria and exclusion criteria. And that's always defined, whatever the study is, there will be a set of criteria that allows a person to be in the study and certain things that would exclude a patient from being in the study. And I'll explain that a little bit further because it's a very important point. When we're looking to see if a therapy will help ALS, we want to use a therapy that has a chance of working. And so we want patients who have relatively recent onset of the illness. If we have somebody that has a very advanced state, the chances of the medication working are less.
How recent?
Well, in this study, the onset was 3 years. You had to have onset of ALS within 3 years. So that's an example. There are other exclusion criteria in this study. A patient could not be enrolled in the study if their breathing functions were poor, as that's a measurement of more advanced disease. And in this study, it was actually a pretty high requirement. They had to have a breathing a forced vital capacity greater than 70%. So that's a pretty high reading. So they had to have good respiratory function.
Okay.
So now, I jumped off onto that because I sort of anticipated that might be important information for your question. But basically, when a trial is available, there's usually an announcement. For example, if a trial of this medication is available, this would be announced on the ALSA website. They would have that information posted. And the local facilities that are taking part will make announcements in the community and in their own ALS population. Patients that are followed, doctors know that this patient would be eligible for the trial, so they contact that patient and ask if you'd be interested.
Okay, and then a follow-up and then a return, if I could. Is it specifically in Atlanta? Have you been any trials there?
Well, there have been trials in Atlanta.
For this one?
This particular one, I don't think so. I can't remember that there was a site from Atlanta.
Okay, and one other thing I'd like to return to. When you talked about the heredity factor, is that generally father-son, mother-daughter? And how about, and do you have any research on grandchildren?
Okay, so it's a big question. There is a lot of information about genetics of ALS. Some very basic information. I would say the majority of hereditary cases of ALS are what we call autosomal dominant. And autosomal dominant means that the gene is directly passed on to the offspring. And that typically will mean that 50% of the offspring will be affected. It's not male or female related. It's whoever has the gene, half of the offspring will typically have it. So what we anticipate in a autosomal dominant condition is that roughly 50% of members in the family will be affected. We'll see it in multiple generations. So it's usually quite apparent that it runs in the family. Now, there are some other types, there are some other patterns of hereditary ALS that are not autosomal dominant. There are some that are autosomal recessive, in which case the inheritance risk is much less for our offspring. But the typical pattern is autosomal dominant.
Thank you.
You bet. Yes?
In one of the first slides, trauma was mentioned as a possible onset. Can you explain that, what that trauma might be and what it might look like?
Okay. Well, this has not really been proven that trauma causes ALS. And if you think about it, you know, there's lots of trauma going on for everybody. But there have been a couple of ideas that support this. We know that, for example, there's a big issue now in the media about football players and their head injuries and what happens to them down the road. Football players haven't particularly had a high incidence of ALS, but they have had a risk of dementia from multiple head traumas. There have been reports, small reports, of patients who are soccer players being at an increased risk of developing ALS. And you know, that information is out there. It's not something that we would say that just because you play soccer you're going to get ALS, but there has been a tendency toward a higher than expected number of soccer players getting ALS. Now, other people might argue that that is actually an environmental factor. It's something that's out there on the grass they're playing on that might predispose them to this. So that's an example that's not really well known. Probably one of the best examples that I could give you is electrical injury. Patients who have had a severe electrical injury will sometimes develop an illness that's much like ALS. So, you know, the idea is out there. It's not proven, but I think the reason it's so difficult is that there are so many traumas that people encounter in everyday life, and the vast majority of people don't develop ALS. And yet there are these small studies that have given examples where trauma has been speculated as the cause. Okay? Yes, sir.
You mentioned people getting selected within 3 years of onset. How do you determine onset of ALS?
Well, it's a very good question. And the truth is we don't really know the answer to that. What we use is the onset of muscle weakness as the definition for when ALS begins. But we know that the disease process actually begins much earlier than that. That it takes a long time for nerve cells to be dying before the muscle becomes weak. But what has been accepted in clinical studies as the definition of onset of ALS is when the patient develops weakness. That's what we use.
Could you say that again, please?
The definition of the onset of ALS for the purpose of clinical trials is when the patient develops weakness. Yes, over here. Yes, sir.
In the 27% of people who try, is there like an outstanding characteristic that like gender or?
Okay. So the question is, in the study group that did not have progression, this 27% that did not have progression throughout the trial, was there any unique characteristic about those individuals? And I have to tell you that I'm very limited in what I can tell you simply because I don't have the information. That has not been shared with us. There is a lot more information to be learned in this study about what happened after treatment was stopped, what happened to people thereafter, and the characteristics of the patients that had their illness halted. Was there anything unique about that? I don't have the answers. I'm sure that will come out as the information is analyzed further. There was another question. Yes?
Two questions, actually. First, how do you determine a patient's starting FRS, and if this phase 3 trial is successful, what is the expected timeline before the drug goes to market?
Okay, so let's see. The first question of how you determine the initial FRS? Well, we just simply do that when we first meet the patient. We take that as that's the first time we make our measurements. We ask, the questionnaire for the FRS is published, it's available. There are a series of questions that ask about different functions, and the patient picks what's the right answer, and then they get a number based on that. So we typically do that when we first make a diagnosis of ALS. So it's not intended to be the FRS at the onset of illness, but at the point in time where the diagnosis is made. So the next question is in regard to when the phase 3 trial of NP001 begins, how long will it take for the drug to become available? I wish I could answer it with certainty. I don't know. My guess is that the trial will probably be either a 6-month or a 12-month trial. And as a trial is being performed, there is monitoring going on, partly for safety, to make certain that there is no adverse event that's harmful to patients, and also for efficacy, that if the medication is clearly working, the trial can be stopped early and say, we have to move forward with this. But the typical time frame after a trial is over is, I would say, at least a year for the FDA to go through the analysis. That's the way it has been. And the time for the pharmaceutical company to prepare for manufacturing, I think if they know they're going to do this, they'll move right on that, but there's another lag there. So I wish I could give you more specific, but I would estimate that it would be at least a year after the study is done.
Thank you.
Any other questions? Yes, sir.
Can you give us any history on Rilotech?
On Ryutech? Well, I can. Ryutech, or Riluzole, has been around for many years. It has been shown to slightly slow down the progression of ALS. It's not a powerful drug. It has a limited benefit. It does not make people feel better. It does not cause functional improvement. The reason that we use it is that it has been shown to slightly slow down the progression, and we don't have another drug. That's really the reason. Many patients, I don't think it's an absolute thing that a patient has to take Riluzole, and the reason I say that is that it has a limited benefit. It's also an expensive therapy. So if a patient's insurance will cover Riluzole, I think it's a great idea. Might as well use it. It's what we have. If the insurance won't cover it and the person has to pay out of pocket, I would have some reservations about spending a large amount of money for this medicine. So everyone has to decide that. And I think the patient who has relatively recent onset of ALS is more likely to have benefit from Riluzole than someone who is far advanced.
What do you consider recent?
Well, a couple years from onset.
Are there side effects to Ryutech?
Yeah, there are some side effects. It's generally well tolerated. I think probably the most common thing that we see are some GI side effects. Might upset the stomach, cause diarrhea or something like that. But generally it's very well tolerated.
Headache?
It's possible. I haven't seen a lot of headache. Whenever you look at a medication, I'm sure you've all done this, to look at the list of side effects. It's huge. And but the reality is most of those side effects don't happen to most people. So there's a long list for every medicine of possible side effects. Usually they're not serious.
So this Rilotech went through this entire gamut that you just explained, and
Yes.
somewhere along the line, someone came across or
Yeah, there were two studies that confirmed that Riluzole worked. But again, what is typically said is that, and this is what came out of the very first study, was that Riluzole tended to, let me just tell you what was used in the very first study of Riluzole. What was looked at was survival. How long did people live? Okay, that's a pretty clear endpoint. The patients who got Riluzole live longer than patients who didn't get Riluzole. And what it showed was that the patients who got Riluzole lived 3 months longer than patients who did not get Riluzole. And when many people hear that, they say 3 months, that's not that impressive. But there have been subsequent studies that have looked at this in larger numbers and younger patients and found that some patients may actually live longer than that there may be even added benefit. So again, it's not a powerful medication, but it's one that has been shown through this process of a clinical trial to have a benefit.
And there is no other alternative as far as slowing down the
Nope, it's the only one, it's the only FDA-approved medication for ALS. I think the results from the NP001 trial are very exciting, that this may be a good medicine. Some of the questions that I've heard people ask is, will there be an oral form? Because it's a big deal to get an IV medication. You know, that's not so easy. And I don't have the answer for you, but I think there probably will be ultimately. That would be ideal if we had an oral medication.
Has this been going on for quite some time now?
The use of this, we just finished in October. The trial was just finished in October. Yes?
I think it's sodium chloride or something.
Yeah, sodium chloride, isn't it?
Is that something found in our diets?
No, it's not. You may have, if you've read about this, that it's similar to bleach.
Bleach.
But that's not. And there have been, on the internet, there have been some chemists that have given a formula for people to make their own sodium chloride, and we strongly recommend you do not do that. Okay? Because there have been people who have really had some harm from ingesting that. It's not. This is a specially prepared formula that can be given intravenously. That's safe. So don't go out and try to find some other.
Sodium chloride is something that's common in our environment, correct? It's nothing.
Yes,
There's nothing unusual about sodium chloride. So how did, obviously somebody not all of a sudden, but upon thorough research, all of a sudden realized maybe we can use this as a...
Yeah, and I don't have all the history about how that came about to answer it. How was it figured out?
Interesting.
What was the question, please?
Oh, well, it's just a comment that somebody figured out that this has a benefit. And I don't know, that's true, I don't know exactly how it was determined that this was effective.
Interesting.
Okay, well, thank you very much.
Thank you, Dr.